Con vosotros el profesor David Veale.
Here we go. So I'm going to talk today about getting the most from exposure, tasks, and behavioral experiments, yeah? Which is at the core of cognitive behavioral therapies. So it's very important that you know how to get the most from it. So it's still the best treatment option. All experts and scientists around the world will agree that for mild obsessive compulsive disorder, and by mild I mean it doesn't interfere too much in your life, the best treatment is cognitive behavior therapy. When it comes to moderate obsessive compulsive disorder, you should be offered either cognitive behavior therapy with exposure or an SSRI medication. I'm not talking about that today. But the reason is that both are equally effective. Yeah? When it comes to severe obsessive compulsive disorder, then you should be offered the combination of the two. It's up to you as to which you should have, but I'm saying the best treatment is probably the combination when you have severe OCD. I have to say, though, that all other treatments, whether it's psilocybin, magic mushrooms, or transcranial magnetic stimulation, or, you know, there are about 20, 30 different treatments available. They're all still under research. Or those that may be promoted may be weak in terms of a treatment still, or just used for mild OCD, or it's used in combination with the above, because very often it's very difficult to separate out the main components. So, before starting on cognitive behavior therapy with exposure and response prevention, it's very important to have the groundwork done, yes? So you can see the gardening analogy from the introduction. It's very important to have your seedlings ready for your garden. And it's probably important to have some understanding of the cause of your OCD, but don't go too much down that rabbit hole, because it's complicated and no one can tell you exactly what caused your OCD. It's partly, as you heard this morning, partly the nature of your brain. Yeah, it's partly the problem of being human. It's a lot easier to be a crocodile or a reptile in some way, because crocodiles don't get OCD. It's, you know, we have a tricky brain, as they say. And there's definitely a genetic component, you know, probably about 40% is heritability, and you can blame your parents if you wish to, but they can then blame their parents all the way back to Adam and Eve. And lots of things happen during childhood and adolescence, lots of things which have shaped you, and there are lots of things which are unknown. Yeah? So it's an enormous jigsaw, and it's impossible to work out exactly the cause of your OCD because all these things interact. So don't bother. You can have some understanding of some of the key factors that might make you develop OCD, but you know, it's not that helpful for getting over your OCD. So, and also have a good understanding of the maintenance of your OCD. This is what therapists call a formulation and understanding. And these include some of the important cognitive processes, particularly things like the need for certainty. Yeah? I have to know for certain that nothing bad's going to happen. And often not knowing something is worse than knowing something bad is going to happen. The way that perhaps you might transfer your thoughts by contamination. So, for example, just touching something and then touching something else means that somehow magically you can transfer that contamination from one thing to another. The way that you define yourself by your feature, by your problem. You know, it's not you, it's just one part of you. And the way all your avoidance and all your compulsions and safety behaviors maintain your problem. So it's very, very important to have a good understanding of what's keeping your problem going. And that's usually best done with a therapist who can think through with you all the things that keep your problem going. And it's important to try to develop an alternative understanding of the problem. In other words, it's not that you are a paedophile or could be a paedophile, it's just you're very fearful of being a paedophile. And once you begin to treat this problem as an anxiety disorder, a fear problem, then it's a completely different solution, because if you are a paedophile, then there are lots of paedophile solutions, yes? Of avoidance and checking and so on. But if it's an anxiety disorder, it has a completely different solution. So it's very important that you agree upon with your therapist about what the problem is that you're trying to solve. And good CBT involves having a good definition of your problems, your goals, and understanding of your values, what's important in your life. And you have to be able to have the right context. You have to be able to feel safe. You have to feel safe with your therapist. You have to feel safe in your environment. And have the right support in terms of your family. And I think also lifestyle is terribly important, to not, in other words, to pay attention to your sleep habits, to your diet, to your activity levels, to whether you're using substances, to your connections to people. All these things are not by themselves a treatment for OCD, but they're parts of the jigsaw. And it's important to pay attention to those as well. Yeah? So, having set the groundwork for all the treating OCD with exposure and response prevention and cognitive behavior therapy, let's see what we can do. So when I talk about ERP and behavioral experiments, they're really two sides of a coin. So exposure and response prevention are deliberate and planned activities that involve facing your fears without any compulsions or safety-seeking behaviors, and learning to tolerate your anxiety. That's the key word, tolerance. Whereas a behavioral experiment is something to test your predictions. Yeah? For example, in OCD, whether your experience best fits with one of those two competing theories, that you are either a paedophile or you're a person who's very fearful and worried about being a paedophile, or that you are contaminated, or theory B is that you're very frightened of being contaminated. You know, which of these two theories best fits the results of your experiment? And so all these tasks I'm going to be talking about are like two sides of a coin. One is learning to tolerate the distress, and the second part of the coin is to test out your expectations and whether the results of your experiment best fit your predictions. And look, it's not rocket science. You know, try to keep it simple, yes? Because that's what essentially CBT and applying it is simple. Well, actually, the principles are simple, but applying it well is difficult. Yeah. And now how am I going to get to hear what Churchill said? If you've got the laptop in front of you, can you just press the little speaker slightly?
I have nothing to offer but blood, toil, tears, and sweat. We have before us an ordeal of the most grievous kind. We have before us many, many long months of struggle and of suffering. You ask, what is our policy? I will say, it is to wage war by sea, land, and air, with all our might, and with all the strength that God can give us, to wage war against a monstrous tyranny never surpassed in the dark and lamentable catalogue of human crime. That is our policy. You ask, what is our aim? I can answer in one word: victory. Victory at all costs. Victory in spite of all terror. Victory however long and hard the road may be.
Yeah, I don't want to draw the comparison with war against OCD too much, but the message really was initially that when we're offering CBT with exposure, all we can offer is toil and requiring a lot of courage and blood and sweat and tears. It is difficult. It's a lot of, hard work, yeah? And I don't want to estimate how tough it is. So, let's try and think about the key principles of exposure and behavioral experiments. So the first thing to do is think about is what tasks are you going to choose? If it's a mild problem, perhaps you're doing this with a self-help book, or if it's a more severe problem, with a therapist and so on. So generally you're going to choose tasks to what you avoid, yeah? What is value-driven, that's what's important to you, and what involves an overlearning, that is anti-OCD, anti-TOC, yes? So, for example, if you are, let's say, a mother with children who has a fear of contamination, that has avoided taking your children out on a day trip because of fears of having to go to a public toilet, yeah? This is something you've avoided. It's something that is value-driven, that's important to you to take your children out, and involves overlearning, because your therapist will want you to touch the toilet seat in the public toilet and touch your children after you've touched it and so on. So that try to choose tasks which involve all of these different components for the best outcomes if you can. So OCD violence, it might involve an anti-OCD actually putting a knife to the throat of your therapist. Yes, if you have a fear that you're going to stab them or kill them. If you've got homosexual thoughts which are very distressing to you, and therefore you're avoiding having a heterosexual relationship because you fear that you might then disappoint them and so on, it's very important that you do have a heterosexual relationship. If you fear flooding, it's very important that you leave the water tap dribbling in order to, and so on. All these tasks are very individual, yeah? They're very idiosyncratic. I don't know how you're going to translate that in Spanish. Idiosyncratic. It's very particular to your particular problem, yeah? And you have to be very creative in the things that you come up with. So the key thing is the purpose of the exposure clear? Can your therapist explain to you the rationale, why you're doing this? Do you have a prediction or expectation to be tested? Have you decided on the location, the time, the resources that you need to do these tasks? Any other obstacles that are going to get in the way of doing this task consistently and regularly, yeah? So don't just pick things out of the air, have some thought in terms of the things that you are going to do. So one of the first things is, how graded should exposure be? So we talk about graded exposure. Sure, start off with easier things, yeah? But be careful, because there is the risk of sticking to easy tasks and not learning to tolerate anxiety. Some people just stick with only very easy tasks all the time. And in general, it's helpful to grade tasks into easy, moderate, or hard, but always challenge yourself. Yeah? Don't do things which are overwhelming, but always find things which are challenging. In general, the theory is that actually it's more effective if you jump around. In other words, that you do things which are sometimes hard, sometimes easy and sometimes moderate, that you jump around your ladder. You don't have to slavishly stick to easy tasks and then the little bit more easier, harder ones and all the way up to hard. It's more effective actually if you jump around. How long should it last for? Well, in exposure, you're learning to tolerate your feelings, yeah? And in general, the elevated fear should be maintained for as long as possible. The old idea was that you should wait for your anxiety to decrease within the session, but it may not. It's much more important whether anxiety decreases between the sessions. In other words, from one session to the next, is it getting easier? Not within the session. Yeah? And in a pure behavioural experiment, it's long enough to confirm an alternative explanation. But the most important thing, the judge, is whether it's getting easier from day to day when you repeat similar tasks. Yeah? How often? Minimum daily. The reason why I've got a saxophone player up there is because I don't practice daily, and that's why I'm never going to be John Coltrane or a great saxophone player. Yeah? Unless you practice daily in your tasks, you're never going to really overcome your OCD. And leaving long gaps between exposure tasks means your fears will easily return. So try to do it as frequently as possible. And your therapist can only act as a guide and supporter, but much like seeing a physiotherapist, you have to do the work. And they can only teach you and guide you and support you, encourage you. You have to do it, I'm afraid. And sometimes with more severe OCD, there may be assistants and others who can help you do it, but you still have to do it on your own as well. And I suppose the message is not just a talking therapy, it's very much talking and doing therapy.
The next rule is that when you repeat the tasks, try to do so in different contexts.
Repeating the tasks,
so for example,
try to do so in different contexts.
Do it now when you're alone.
For example, when alone, when unfamiliar places, different times of the day, and so on. Don't do the same thing over and over again, because it's okay, but it's much better to do it in different contexts, different situations, different times, of different people, and so on. Yeah. It's helpful to label the emotion during your emotion and encourage yourself.
So, for example,
in general, don't rationalize what you're doing during exposure. Don't criticize. Don't reassure yourself. Don't compare. Just shut up and just do it. Yeah? Yes, it's helpful to, as I said, label. These are my feelings of anxiety or disgust.
We don't want you to be getting into rationalizing it and reminding yourself that it couldn't possibly be dangerous or something.
I think it's actually, don't worry, it's my fault.
Criticize yourself.
I think it was definitely an auditory hallucination though. No, everything's okay, everything's okay. Don't panic. Don't panic. It was just on the slide. Right. So all I was saying before, don't rationalize, criticize, reassure yourself. Don't say anything in response. Just tolerate the feelings, label the emotion, and it'll fade. And you remember we said right from the beginning, you're testing your expectations. You're a scientist. And after this task, you've completed your experiment, and just reflect on what you've learned. For example, your expectation, did it last as long as I predicted? Did the anxiety last? Does the outcome best fit with theory A or theory B? Theory A, for example, is that I'm a paedophile, or that I am responsible for transmitting contamination all over Granada. Theory B is that I have worries about being a paedophile. The more I avoid, the more I lose my confidence and the more convinced I am a paedophile. Or that I am one of the worst people, I'm a psychopath for creating all this contamination all over Granada, or whatever. So your therapist or supporter, assistant, whoever, may model the task first, and they may be eating crisps off the toilet seat or whatever before you do, but in other words, it's helpful for that person to do it with you. And sometimes, particularly a lot of therapy now is online, so you have to be creative. You may have to wear your phone or whatever around your neck and show your therapist what you're doing, so that it's not just talking, it's hopefully within the session there is also that doing. But in general, it's often helpful for your assistant or supporter to be doing the task with you so that you can then do it second. And try to integrate your exposure tasks into everyday activities. Don't avoid a sex relationship even if that distressing image pops into your head when you're having sex. Have a knife or whatever to hand so you have plenty of opportunities to stab your relative. Deliberately try to transfer thoughts when you have the opportunity. So you can integrate them on top of the planned activities, because things will come up during the day that you hadn't necessarily anticipated. So, but it's not, exposure is really planned. It's not, but sometimes, of course, things will be triggered, and you can incorporate it to when it gets, the exposure tasks into when it is triggered. Now, this is a tricky one. Exposure in real life versus imagination. Sometimes it can be helpful to externalize those thoughts that you have, the intrusive thoughts. And this is where there's a lot of research at the moment in terms of trying to understand how best to deal with those internal thoughts by exposure or other techniques like imagery scripting and so on. Some people have tried to make an image worse and make it more and more ridiculous, or like a cartoon so you can laugh at it. But you've got to be really careful that you're not neutralizing the image or thought. In other words, that it doesn't become a compulsion as a way of trying to get rid of it. And that's, as I said, is quite a complicated discussion. Some therapists will encourage exposure and imagination to their worst fears as a narrative. So, for example, if you fear being a paedophile or something, it's not so much writing detail about being a paedophile, but more the long-term consequences, like going to jail and all these other things and being humiliated. But this is a difficult thing to discuss in a lecture. It's quite complicated, it's complex, so I don't want you to go away and just do some of these things. It is complicated in some of these more unacceptable thoughts. It's highly individual, and you've got to be careful if it's linked to a trauma memory, for example. So that's why I'm saying it requires a lot of understanding of the nature of the problem. But often, the principles, as you heard in the first talk, was to try to distance yourself. For example, you might be trying to walk along the side of the road. You're aware of the passing traffic, but you're not trying to control it. You can never get rid of the traffic. If supposing in that traffic out there, you can see the red cars might be the thoughts you don't want. You're never going to be able to stop the car. If you do, you just get mowed down. And you can never just divert the traffic. You'll spend your whole life in your head trying to get rid of the cars down a different lane. You can never get rid of it because only zombies don't have thoughts. The only time you'll never have thoughts, as it were, is when you're dead or whether you're turned into a zombie. But here's the caveat. This is difficult, extremely difficult when you have OCD, yes? To be able to do this type of detached noticing, mindfulness, awareness of the world. It's very, very difficult. It requires a lot of practice. We want to help you to gradually remove the things you do to reduce anxiety, give a sense of control, of certainty. So if you have OCD contamination, you might be using your gloves to touch the door handles. This would be known as a safety behavior. You might be using a pair of padlocks to stop yourself from being violent. Yeah? So always try to think functionally. How does this serve me? Is it something that's helping me to avoid, and prevent me from testing out my fears? Because that is a safety-seeking behavior. And obviously we have to try to help you to get rid of these safety-seeking behaviors and safety objects. So the other problem is that a lot of those safety behaviors are in your head. Yeah? You carry them around with you. And if supposing you are analyzing the task or repeatedly reviewing the evidence very carefully to make sure something's safe, forcing yourself to relax and be calm, using affirmations, telling yourself something's safe for a particular phrase, distracting yourself, switching yourself off, trying to transform the image or neutralize it, undo it. All these things are very likely to be safety behaviors, and are unhelpful in the long term. They maintain and keep your OCD going. So it's a habit, another habit that you've got into, that works in the short term but maintains the problem in the long term. So always think functionally. What's the intention behind what I'm doing? Something that we have in our anxiety disorders residential unit at the Bethlehem Royal Hospital is a OCD bully. Yeah? And we encourage our residents and patients to put all their safety objects inside this giant dustbin that the bully carries. And you can see in there a bottle of bleach. Yes? You can see a pair of handcuffs. You can see an old mobile phone that was being used for reassurance. So all your safety objects are placed in this. Over time, of course, it gets full of clutter that we then have to remove. But I think my wife Elizabeth called it as a giant dustbin. It is, because we're trying to help our residents to get rid of their safety objects. Yeah? And of course, the actual bully here, the OCD bully, has a depiction of all the different aspects of OCD. So on the outside here, you can see a toilet seat. You can see 666, the devil, horns of the devil. You can see the wasted time of compulsions. You've got a bit of poo, feces down here on the foot. So all the fears of OCD is on this bully. It's got paedophile written there. And inside here is a heart of stone. The bully has a heart of stone, yes? And it's all the wasted time of the compulsions and the chains of the compulsions, ropes and things. Fears of stabbing, yeah? So one of my fantasies is, before I retire, is I'm going to have lots of different bullies all around our hospital. We're going to have an anorexic bully. We're going to have a depressed bully, a borderline bully, and so on. And each of the different wards around the hospital. Because I think this is art, but of course it's by a colleague of mine, Steve Kaplan. But it does help individuals really understand and externalize their OCD as to what they're battling. And one of the key things as a part of exposure and response prevention. It just means stop doing your compulsions, yes? If you ever want to have a laugh this evening, before you go to bed, do watch Just Stop It by Bob Newhart on YouTube, because this is where he takes a big joke out of behavior therapy. Yeah, it's very funny to watch, and just tells his patient just to stop it. When we're starting to try and help people to stop their compulsions and their compulsive washing and cleaning and checking and ordering and so on, it's very important to understand the motivation. It's usually about trying to help prevent harm, to stop you feeling uncertain in some way. And it's helpful to try to identify the criteria used to finish the compulsion. So for many people, it's about feeling comfortable, feeling just right, feeling certain. And, this is normal in some contexts, but of course it's problematic in OCD. So you have a very important decision, for example. You will probably decide who you get married to or where you're going to buy a home on the basis of whether you feel comfortable and whether it feels right. Yeah? But when it comes to washing your hands in a compulsive way, it's not helpful. It's what we call an elevated requirement to finish your compulsion. So it's why important to have just objective criteria to finish when you can see your hands are clean, or you finish when you can see that the light is switched off, not on the basis of, in other words, of when it feels right, when it feels comfortable. And it's very important that even if you stop doing these compulsions, that you don't overcompensate. That is, you avoid touching things more because you're washing your hands less, and so on and so on. Don't let the seesaw swing between doing less compulsions and doing more avoidance. Yeah? So there are generally 3 different ways of dealing with compulsions. The first is called ritual reduction, where essentially you reduce the frequency of compulsions, how often you're doing them. It's not generally recommended because, if you go from washing your hands 100 times a day to 95 times a day, yeah, or checking from 60 to 55 or something, you really haven't achieved very much because you haven't learnt to tolerate anxiety. Yeah? You may have just perhaps sped up your compulsion and made it faster. Yeah? Then we've also got ritual delay, to delay the compulsion until you do it, as it were. It's okay if it's a means towards an end, and you do actually, in a reasonable period of time, do end up stopping it. In general, it's better to do exposure after the compulsion. In other words, if you have just washed your hands after half an hour, spoil it and touch the toilet seat and then go and touch your relatives or wherever it is that you fear. Yes, you're spoiling all that compulsions that you've just done. Or, leave the tap dripping even after you've spent half an hour trying to tighten it or whatever. If you can, spoil it. A lot of people start to think of compulsions as habits, and it can be quite helpful because sometimes compulsions are very involuntary, very automatic. In other words, that you do them mindlessly without thinking about them. So it's very important to increase your awareness of when the compulsions occur. And it may be helpful to keep a record of the context, in other words, where you're doing the compulsion, how you're doing it, and the sequence of events in the compulsion, because you can then break it down and try to stop it at an earlier phase. And much like treating other habits, like hair pulling and so on, you try to find a behavior which is incompatible with the compulsion. checking the water tap, you leave the water tap dripping. In other words, this is incompatible with the compulsion. Yeah? But this has not been fully tested and evaluated. It's just that it can be helpful to become more aware of when you do it and try to find something that is incompatible with your compulsion. What about reassurance? Well, reassurance is another compulsion. Traditionally, people were told, no reassurance, hospital says no, or whatever. But that is really like a blocking of the ritual. And blocking is often by itself unhelpful. So, for example, the individual may be more seeking self-reassurance. They're just telling themselves the things that their relative or family member might have told them. So it's very important that they have a good understanding of how reassurance works and really understand the long-term helpfulness of reassurance as a ritual, and to provide an alternative. And what we would say is it's important for loved ones to be able to provide compassion and emotional support, but not discuss the content of the worry. In other words, I understand, darling, this is tough, this is difficult, but let's just stick with the plan. Let's just do the exposure. Yeah? Not to mindlessly give some, reassure them that it's not dirty or something. Yeah? So emotional support, compassion is good, but discussing the content of your worry is unhelpful in the long term. So how do we deal with those mental compulsions? Do you have rabbits in Spain? I'm sure you do. So you have, in England, we have these rabbit holes. Yeah? And so we often talk about compulsions, mental compulsions, as going down rabbit holes. And it is very important to be aware of when you're going down a rabbit hole in terms of trying to get the perfect answer, to get things sorted in your head, to do a mental compulsion and mentally review all your actions. So it can be helpful to perhaps use a tally counter, you know, on the plane when you see the air hostess going down the plane with a little clicker, yeah, like that, to be really becoming aware of when you're doing a mental compulsion. Because that self-monitoring increases your awareness, because you can't really choose not to go down the rabbit hole unless you're aware of when you go down the rabbit hole. Yeah? So increase awareness and spot your rabbit holes coming up. Yeah? Pay full attention to the world as it is, not how you feel. Because one of the problems in OCD, or many emotional disorders, is that you are living in your head. It's very dangerous to live in your head. It's more important to be able to live in the world around you as it is, not how you feel. And once you're more aware of the rabbit holes as they come up on your path, and the things that you're doing is important in your life, your value directions, then you can either to choose to go down the rabbit hole and see what effect it has, or stay on the track and do the things in life which are important to you, despite the way you feel and despite your intrusive thoughts. Yeah? This is a difficult thing to do, and it requires a lot of practice. But if we could have a little machine that monitors exactly where your focus of attention is, and whether you're paying attention to the world around you or your inner world, I would love it, because I think I'd make a lot of money. Because this would be a really helpful machine to have, to be able to be aware of where your attention is. Is it in your head, or is it in the world around you? Yeah? It's not a bad thing to be in your head, you know, if you are writing a novel or being very creative or trying to solve a problem, that's great to be in your head. But if you're trying to solve a contamination problem or something, it's not helpful. Yeah? You have to really be aware of the world around you more. Very often people will say, with anxiety disorders, give me a technique, give me something to do. yes, to get rid of these thoughts or to feel less anxious or so on. The most important thing actually is to do nothing, yeah? Or to do the things in life which are important to you despite the way you feel or despite your intrusive thoughts. But in general, do nothing. And say nothing in response, yeah? You don't have to criticize, you don't have to reassure yourself, you don't have to do anything with these intrusive thoughts or feelings. They're just there. Do nothing, say nothing in response. And there are lots of things which are being researched. One of the things that I'm particularly keen on, and for my colleague that developed it is Paul Gilbert, is self-compassion, because it may be helpful to feel safe in doing the exposure and response prevention. One of the things about self-compassion is learning how to feel safe with yourself. Because we know that exposure is going to be less successful if you're going to be very self-critical and telling yourself what an idiot you are, or have a very harsh tone in your inner voice and grit your teeth and so on. Because compassion is about being sensitive to suffering in yourself and to others with a deep commitment to try to alleviate and prevent it, yeah? It's two sides of a coin, learning to experience and to tolerate, to be empathic, to understand it, and the other half of the coin is facing it, approaching it, and encouraging yourself. And so it may be helpful when life is difficult to talk to yourself in a calm, caring way and encouraging yourself to approach difficult situations and tolerate distress. That's the basis of self-compassion. But again, this is a difficult skill because it may have been something that you've learnt over many years to be self-critical and judgmental. And, trying to unlearn a particular pattern of thinking and behaving is tough. You're not going to do it in short-term therapy. It takes often a long time, over the year or two, to really reverse a pattern of thinking and behaving. So, why does exposure response prevention go wrong? Yeah? So, the first I'm going to call the 6 C's. This doesn't work in Spanish, I don't think. I doubt if all the Spanish words that begin with C in English. Maybe you can tell me after this, but it's all about control, comfort, courage, confidence, and feeling complete. They can't always all be C's in Spanish, are they? They are. Oh, great. So, what many attitudes and assumptions in people with OCD might be, I have to know for certain that harm will not occur before I do this exposure task, yes? And we'll talk about that in a minute, but they're wanting a guarantee. I have to know for certain. I have to be in control. Control is very important. I have to know what's happening exactly. I have to influence things. I have to feel comfortable before I do this exposure. I have to have the courage before I do it. I have to have the confidence before I do it. And I have to feel complete or just right before I do it. Yeah? This is what we call putting the cart before the horse. Now, can you translate that in Spanish? I don't know if it makes sense. But, yeah. Because you will get the comfort, have the courage, feel confident or complete after you've done the task, yeah, regularly. You can't have it first, yeah? You have to first do it uncomfortably, uncourageously, unconfidently, and feel incomplete, yeah? This is one of the biggest obstacles, I think, to doing good exposure, because one of these attitudes behind it is preventing you from doing it. So let's think about control. And as I think you've already learned, the more you try to control or influence internal events, whether it's your thoughts or your feelings and so on, which are not in your control, the more you feel out of control. Yeah? And you see this, of course, in magical thinking, all those doubts you have, and so on. Give up control. And I have to know for certain, or I have to have a guarantee that what I fear will not happen. Yeah? Sorry. There are very few guarantees in life. The only guarantees I know are death and taxes. I bet you that's the same in Spain. There is a third guarantee, that you'll have OCD for the rest of your life while you continue to demand certainty that your bad event, that no one's going to be harmed or whatever, is not going to happen. Yeah? It's very important, this. Or if you want to reduce a major risk by 0.00001%, it incurs a 100% chance of having OCD and other consequences and messing up your life for the rest of your life. Yeah? So it's a cost. And this need for certainty often leads to avoidance in decisions. Yeah? Do you know about the camel in the desert? Remember the camel in the desert? No. Well, maybe, yes, there's a camel. It's pretty desert-like around here, isn't it? So there's a camel, and it has two wells it can go to, two paths to go down. And it knows that at the end of these paths, there is water in a well. But one of these wells has got dirty water in. Yeah? And he doesn't know which one. Should I do this well or should I do this well? Yeah? And so what happens, of course, is that the worst that could happen is that it might get ill for a few days or something if it had the dirty water, but it's stuck, isn't it? It can't decide. And so there it is, it shrivels up in the desert. It's made as, it can't make a decision. There are consequences from not making a decision. Yeah, if you're going to be like that camel in the desert, you don't take a risk, yeah, there are consequences. So give up this demand for certainty and guarantees that something bad is not going to happen. So one of the things we often see, and I tend to see a lot of people who've had a lot of therapy and medication and so on, if at first you don't succeed, try again, but learn from the last time. Yeah? Let's find out from the last time therapy you had, why didn't it work? Was the exposure not frequent enough? Was it not challenging enough? Was it done with compulsions and safety-seeking behaviors and other subtle things? Was it only done with lots of discussion, or whether it was only done accompanied? Was it done with a lot of reassurance? Was it done without testing out a theory or your beliefs? Was it that the ritual prevention was too limited, or you substituted another ritual? So often people say, oh, I've had one round of CBT or 3 rounds and it didn't work. Well, let's find out in more detail exactly what you did, what you learnt, and why it didn't work. Yeah? Because that's why it didn't work, probably because one of these things. Yeah? So if at first you don't succeed, try again, but learn from the last time. And you can learn more in our book. I understand that you can, if you get a Kindle version, you can translate it into Spanish as you go along. It's a workaround, and maybe someone wants to translate it and whatever, but there you go. I'm also quite keen on death anxiety, if anyone's interested in death, because often that pops up as a common theme in OCD, and emetophobia, vomit phobia, is again a common theme in OCD. Yeah. So, if you're ever in London, do come and see the Museum of the Mind in our hospital up there. You can see, if you came to our hospital in the 14th century, you would meet these two statues at the entrance of the hospital. One was depicting raving madness, and the other one was melancholia. It was a pretty scary thing to do, but it's a very interesting museum of the way that madness and that way that treatment has evolved over the during the ages. Great. So I'm very happy to take questions.